At this point, we'd like to start the conference itself. The first talk of the conference is the Thomas WACHTEL keynote lecture, and this lecture will be introduced by Dr. WACHTEL. Dr. WACHTEL won 11 Navy awards, medals, and accommodations, served in Vietnam, was the ship's surgeon at the Gulf of Tonkin from 1969 to 1970, served on the USS Ticonderoga Constellation, and did Marine casualty care in Da Nang. Went to Naval Flight School in 1970. After his military career, he had a 27-year career as a trauma director. He taught at 4 universities, received 27 research grants, wrote 9 books that were published, 22 book chapters, 145 professional articles, and 3 novels. And so the STACS conference is named after Dr. WACHTEL for his significant contributions. And with that, I will have Dr. WACHTEL introduce our speaker.
Well, good morning, everyone. Thanks for being here. Next. My job is to introduce our keynote speaker. This is all in your handout, but the speaker this year is Dr. Ronald Stewart, who is professor of surgery and anesthesia and the Russ Chair of the Department of Surgery at the University of Texas Health Sciences Center in San Antonio, and he's been there since 2008 as the chair. He's also the chair of the Committee on Trauma of the American College of Surgeons. Next. He was actually born at a young age in Illinois, but at age 2 they moved him to Texas, and he's been there ever since. He grew up with that metal landscaping that you see with those heads that bob up and down. And he learned to drive fast cars and big machinery. And every Friday night, while they had a football game, Dr. Stewart played soccer. Next. He did his undergraduate work at the University of Texas Permian Basin, which is in Odessa, and then went on, matriculated to the University of Texas San Antonio, where he got his MD, and he stayed there for his surgical residency. And finally, the state of Texas granted him a passport, and he got a visa from the University of Tennessee and did his trauma and his surgical critical care fellowship in Memphis, which is one of the bigger and busiest trauma centers in the country. Next. He came right back to the University of Texas in San Antonio as the director of trauma services in 1993. Then Governor Bush appointed him to the Emergency Medical Services and Trauma Advisory Committee, Council, and he served there for 14 years. Was the chair of the South Texas chapter of American College of Surgeons Committee on Trauma, and then followed that with being a chief of Region 6, which is 4 states. And then, as I mentioned, he now is the chair of the Committee on Trauma in the American College of Surgeons. He was the founder and first chair of the National Trauma Institute and is a member of the Board of Governors of the American College of Surgeons from the Southern Surgical Association. Next. Probably his strongest suit of all of his academic affairs is his teaching ability. And here I pulled out 3 awards which kind of sum up what he's wrapped into his teaching acumen: clinical excellence, distinguished alumnus, and humanitarian in medicine. And what that translates to in training residents is what I call the residence mantra, and it's the WWDSD. Next. Now, one of his residents spelled this all out for him, which is that it's a model of civility and humanity and humility, 2 things that they think are not present and when they hone down trying to improve their surgical skills, when actually they should be looking at the trauma and surgical patient. His character is that solid grounding that we aspire to, even if we forget for a brief period. And that WWDSD is, what would Dr. Stewart do? And I think as a teacher, you couldn't have something better than that. Next. His research is rather healthy. He currently has a grant for $6.6 million, and he's closed 32 grants from almost $19 million. Next. His academic writings are many too, and I pulled about 5 chapters out of the 14. You can see they span such things as trauma systems, colon trauma, perineal injuries, and multi-system trauma priorities. And he's written in the Feliciano, Moore, and Maddox Bible on trauma. Several editions on wounds, bites, and stings. And I pulled 3 articles out of the 90 or so that he's written. And you can see these 2 spread over the entire banner of various injuries, from diaphragmatic injuries to surgeon's performance to the lead author of a multi-center study on conservative fluid administration. Next. He belongs to a number of organizations. These are just some of them. He belongs to the oldest and most distinguished American Surgical Association, also to the Southern Surgical and the Western Surgical. He currently is also president of the Southwestern Surgical Congress and secretary of the Texas Surgical Society. He is a board chair of the Southwest Texas Regional Advisory Council for Trauma. Next. Next. Here are a few more awards, and you can see that they punctuate a remarkable career. He's a faculty member of the year in 1999. That's 6 years after he came back to the University of Texas Health Sciences Center in San Antonio. He has a Bronze Quill Award for writing an injury prevention program. He was a National Safety Council Surgeon Award for service to safety. In 2013, he had the college's Ellenberger Award for excellence in state of advocacy. And he has an honorary membership in the Eastern Association for Surgery of Trauma. Next. His hobby is photography. You can tell he always got a guy with his eyes on something little with a big camera. And here you can see him also taking a side flash of a small flower. Next. And he also takes good landscape. This is Texas in the springtime. Next. He has a nice family. You can see in the left upper corner, you can see Dr. Stewart when he was a young man, his grandmother, his mother, and his brother, Donald. And the right upper thing is his wife and girlfriend, and she's got one of those Texas I've got you holds on him. And in 1982, they were married when he was early in his medical school. And you can see he's got that big wide smile on his face. And then the picture in the center is his wife, Sherry, and a more contemporary picture. And actually that picture and the picture of all of his children, guess who took it? So he's got Elizabeth, Jackson, and Mary. Next. So sit up, lean forward, pay attention. Perspectives and leadership in a regional trauma center. Dr. Stewart.
It's working? Yes. Thank you very much for that kind introduction. It's an honor and privilege to be here. And I'm very grateful to be here. In a way, my talk will be a little bit about, talking to Dr. Natrika, a little bit about the Arizona Trauma Association. And like I said, it is really an honor to be here. And with the list of speakers, I'm really aware that there are many others actually on the panel who are more qualified than I am to give this talk. But I'm going to talk about regional performance improvement from a leadership point of view. So I'll talk about the problem, where we are today. We've got 7 P's to be. I'm going to talk about behavior and behavioral health. I'm going to talk about perspective. And I'm going to really emphasize the importance of your leadership. And when I'm talking about leadership here, it's particularly in the context we're talking about. You don't have to have a title to be a leader, and everyone in the room is a leader in your own way. And so that'll be about the theme of the talk. The problem, you're going to hear about it this next 2 days. More than 167,000 people die every year, 1 million disabled in the U.S. alone, 10 million lives worldwide. It's one of the top 3 most expensive healthcare problems in the U.S., and it's projected to be the leading cause of death worldwide by 2020. So why do people die? You know this. I'm lumping here to be very simple. They die from 2 primary reasons: central nervous system trauma, primarily brain injury, and shock, primarily from bleeding. A smaller subset die from sepsis and multiple organ failure, but in many ways the goals of your trauma system are to either prevent these injuries from happening or to effectively treat these injuries. The pillars of a modern trauma system, this is the way I think of a modern trauma system, are prevention, acute care, that's typically what most people in the audience do. That's hospital care, EMS, the communication centers, surgeons, nurses, paramedics. Rehabilitation, and then in the past decade, trauma systems have been used as a framework for both disaster response and other time-sensitive medical conditions like stroke and STEMI. The next 2 days, you're going to hear about these modern advances. It's quite impressive. The improvements in care, particularly the improvements in care over the past 40 years. It is a testament to your work and your dedication that things have improved so much for the injured patient. The outcomes have been significant reductions in death and disability, improved access for care for injured patients, increased sophistication of trauma systems, and even though it wasn't intended, increased funding for trauma systems, trauma centers. This just shows that data. The bottom right graph, a very simple graph just from one state, shows that since the time I was in high school, if you look at improvements in mortality, there's been a 35% reduction in deaths during that time, which equates to 6,720 lives every year of people who would have died. So we talk about trauma systems. I talk about trauma systems. It's like some sort of magic. It's like people with trauma systems, this has to do with the... Try explaining that to someone. It's very difficult to explain to your neighbor, what is a trauma system? Well, how do they save lives? Well, trauma systems save lives by setting and verifying standards, which move the treatment bar, ensuring availability of resources for the injured patient, coordinating care, and improving performance. That's what we do. That's what you do. In a way, I don't know how much you've thought of it, in a way, it's like evidence-based self-governance. The people in this room, the people like you and the other states across the United States and territories of Canada and countries across the world, are the ones who've set those standards. So essentially, you're setting standards for yourself, which is pretty unique in a modern world. Talked about this. These pillars of the trauma system, though, if you look, require timely, structured cooperation and communication. So what that means is people have to work together. If I'm injured or if I'm hurt, people have to work together. So there's many challenges to leadership in a regional context. Other than yourself, you control nothing when you get in a room with your peers. It's not your organization. There's no CEO. And there's a range of participants with a broad range of experience and skill sets. There's competitors in the room. How do you work with your competitors? There's politics. There's geography. But the truth is, in a regional trauma system, even though you control nothing, you as a person, you as a leader, can influence virtually everything. And you can really make a difference. So I'm going to talk about pearls and pitfalls for leadership in a regional trauma system. I have a lot of experience in this. There's some things that I do have a tremendous amount of experience. I've been in a regional advisory council for 20 years. I've been the chair of it for 20 years. We've never had a non-unanimous vote in the entire time. And we've done some really controversial things, some things that I thought were crazy. This is a sign that reportedly hung on Albert Einstein's wall. That I have some data, but I don't have a lot of data for this. But not everything that counts can be counted. I need your attention with respect to this, so I'm going to talk about end-of-life regrets. When you look at people, when you survey people and you talk to people who are at the end of their life, they have some regrets. And the regrets can be lumped into some broad categories. The regret of not spending enough time or attention with friends and family, and not mending broken relationships. It's a common theme. Chasing after happiness rather than choosing happiness in what we're doing now. And a failure to follow dreams or a failure to take a stance or a chance. If you look, those are three broad areas that people, when they have regrets at the end of their life and speak to people honestly, talk about. I will say this rings true to me. December 21st, 2011, I was sitting at my kitchen table doing some online Christmas shopping. I was actually supposed to be traveling through South Texas and rural Texas. But all of a sudden, the world really grayed out. I realized I was losing consciousness. It was really a struggle to maintain consciousness, and I lost consciousness. As I started to regain a certain level of consciousness, I realized that I had a dense right hemiparesis and expressive aphasia. And my daughter was there, fortunately. And I had lived with lone paroxysmal atrial fibrillation for 10 years. So as my computer is starting to reboot, I'm realizing that I've had a stroke or had a seizure. So I tried to say to my daughter who was there, I tried to say, I need a doctor. But what I said is, I need my friends. That's what people with expressive aphasia do. They substitute words. So I said, I tried to then to say, I need to go to the hospital. And I said, I need to go home. You can imagine if you're a 22-year-old there listening to this, first she thought I was teasing. Then I could, again, trying to substitute words, trying to say it again, I said, I need a neurologist. My daughter looked at me and she said, Daddy, I didn't think you were friends with the neurologist. So, words starting to return, brain starting to work again. Still had a right hemiparesis, but I got out the words that I think I'm having a stroke or I've had a seizure. And she jumped into action and activated our emergency system, where I went to see my friends, actually, and within an hour I had TPA. And I was essentially pretty much normal by that evening. So I know that you have stories like that of people you care with all the time. I also know that you don't appreciate some things about it. So I'm going to speak to you as a patient, and I will say that my overwhelming emotion with respect to that was gratitude. I have still not adequately expressed how grateful I am and I was to the people who saved me. And just because your patients can't express it adequately doesn't mean that they don't feel it. We don't have a culture that's really strong in expressing gratitude and joy. I still cannot describe it. I will say, and it sounds weird to say it, but I will say that's probably one of the best things that happened to me, other than my wife and my kids, because to know that and to feel that joy of simply being able to speak, of simply being able to walk, it's incredible. I also gained knowledge. One of those pieces of knowledge I'm going to emphasize to you is we do not have unlimited time. You do not have unlimited time. I do not have unlimited time. The things you need to do and the things you want to do and the things you need to do for your patients, you need to do it now. Not tomorrow, not next week, not a year from now. The time to mend a broken relationship is now, not later. You may not have later. It's very interesting. If you look, surveying people who are near death, and then surveying young people who are organizational stars in Fortune 500 companies, they essentially say the same thing. If you ask people why they're staying in their company, why they're staying there, and these are stars picked by Fortune 500 companies, they say, why are they staying with the company? They say, I'm finding meaning and happiness in what I do. I like the people. They seem like family. It's a team. I can follow my dreams, and I feel that I'm having the opportunity to follow my dreams. This is a really good book by Marshall Goldsmith, What Got You Here Won't Get You There. And he draws that parallel really well. And so I believe this is very true, that today, especially in healthcare, money is no longer the most valuable asset. It's the people who are the most valuable asset. The people and the talent. And these are the people who do develop regional trauma systems. These people, you, the people in this room, are the most important asset for your trauma system, for your patients, and for your healthcare systems, for your EMS agencies, for your hospitals, and for your organizations. Mentors and family. So I'm going to say thank you for everything that you do. It's very much appreciated. The people you care for, even if they don't all express it, it is very much appreciated. Key principles for you as a leader in your system. Be a problem solver. I'm going to talk about it. Promote a culture of yes. Medicine tends to have a culture of no. Be friendly and collaborative. Be perseverant and participate. Be conscious about your leadership. I'm a Department of Surgery chair, and I will just say it is far more likely, if I'm not conscious about what I'm doing, it is far more likely that I will do unconscious harm than unconscious good. It's very important to be conscious about what you're doing, to make conscious decisions with respect to your leadership in your regional trauma system. And it's very important that you realize that your leadership is absolutely critical. There is just no substitute for it. There's not a substitute for it. 7 P's to be. I think I learned these 7 P's from the American College of Surgeons Committee on Trauma and from the Southwest Texas Regional Advisory Council for Trauma. Participate. Be friendly and collaborative. No one wants to deal with a grumpy person. You don't want to deal with me if I'm Mr. Hardass. You don't. I know it. Be professional. Be true to our profession. I'm going to talk about it more. Promote a culture of yes. Use proven performance improvement processes that work. Be passionate, be perseverant, and be patient. It's also very helpful, and I'm going to talk about it to have perspective and vision about the profession and about your system as a whole. It's important to be evidence-based. It keeps you from doing crazy things. It keeps you from doing crazy things. And be evangelical. It's important to get the message out. It's important to spread the word. It's important for you to lead that way. If you're shy and you don't want to do it, the positive message doesn't get out. It doesn't get out on its own. People are going to be focused on other things, like Donald Trump. They're going to be focused on crazy things. I'm not kidding. Participation, I'm going to emphasize. This is Benjamin Franklin. Tell me and I forget, teach me and I may remember, involve me and I learn. There is no substitute for lack of participation. If you're a young person early in your career, it is absolutely critical that you participate. There's no substitute for it. Your grandmother was correct that showing up is important, and if it may not be 90%, but it may be 75% of it is participation. And for many people, myself, remember I came from West Texas, where if you string together 3 sentences, that's talking too much, honestly. It will be uncomfortable in the beginning, but comfortable in the end, because as you participate in your own organization and your regional trauma system, and you participate with colleagues in your professional organizations, you gain friends. Those friends become collaborators, and those collaborators become partners. That's what happens if you participate. It's critical. Professionalism. I'm going to talk about what I mean by that. Benjamin Franklin said this: "Sell not virtue to purchase wealth, nor liberty to purchase power." So think about it for a minute. Sell not virtue to purchase wealth, nor liberty to purchase power. I wonder what he would say today. And I'm going to say that Benjamin Franklin said this when he was about 30 years old. And I believe there's lots of Benjamin Franklins still here. The question is, not are they here, the question is, who are we listening to? That's the question. The role of the professional, the physician, nurse, paramedic, administrator, is a moral conduct serving a greater good, service to the patient above ourselves, empathy, civility, a specialized body of knowledge, continuing education, and certified competence. That's our role. It comes professionalism. If Dr. WACHTEL would have surveyed me whenever I was 18 years old in Odessa, if someone had asked me what the word professional meant, I would have said, it means you get paid for playing football. That would have been the extent of my understanding at the time. But it actually comes from the Latin root, and the closest modern language to Latin is Italian. And if you go to professare in Italian, it means to confess or to profess. To profess. In the beginning, the professions were a profession. They were a profession. What is it that we profess? It was a profession of faith in the beginning. And so what is it that we profess? The profession of medicine, of nursing. What do we profess? We profess that we dedicate ourselves to the patient before ourselves, and we profess that we will base those decisions on scientific truth as best we can understand it. That's what we profess, and that's why the patients trust us. Violate those two things, and we do it at our own peril. and our patient's peril. David Hillis, chair of medicine, at a white coat ceremony, I took the time one time to poll our faculty up there, what is professionalism? What's that mean? He says kindness, courtesy, following the Hippocratic Oath. It also means competence, because without competence, it's fraudulent. Pretty good. Rakesh Khurana, who's now dean at Harvard College, sums it up. I like this overarching definition he uses. I will create value for society rather than extract it. A very high-level definition of professionalism. There's definitely external threats to professionalism. I was talking to some people outside about them. Economic pressures, market forces, focusing only on those market forces, technology, and quite frankly, broader changes with respect to incivility and bad behavior. I worry less about the external threats, though, than the internal threats. To me, the internal threats can be broken down into two broad areas: a failure of our vision and bad behavior. I'm going to talk on those two things. What is the cost of bad behavior? Samuel Johnson, spite and ill nature are the most expensive luxuries. What are the costs of a lack of vision? I can tell you that if we do not hold true to the professional model, if the people in this room, in rooms like this across the world, do not hold true to that model of professionalism, of what we profess, if we don't hold true to it, it does risk becoming lost in a vacant corporate-owned lot. The next P, problem solver. I said we have a culture of no. It may just be the people in my organization, maybe it's me with the culture of no, but I think it's prevalent that if you talk to people across the world, when you ask someone to see somebody at 2 a.m., are they really happy to come see them? No, they're not. In some organizations, you have to go through 5 layers of no before you can get to a yes. We should model and promote a culture of yes, a can-do. For those Spanish speakers in the audience, sí se puede. Can do. And I can think of myself as having 3 levels. Am I a problem creator? I hope not. I know I do create some problems, but am I a problem creator? That's a big problem. But most are not problem creators. But most of us, without conscious thought, actually become a problem studier. We study the problem. We don't solve the problem, we study the problem. Be a problem solver. For heaven's sakes, don't create them. In the last of the 3 P's, the paradoxical P's, be passionate, patient, and perseverant. Passionate people oftentimes are not patient. They're not patient. It's very important to be both passionate and patient. If you're passionate but not patient, the things you want to do don't ever come to fruition. If you're not passionate, you never move to doing anything. And be perseverant. I'm going to talk about the verification review program of the American College of Surgeons, but it went for about 15 years before it came to fruition. Be perseverant. Talked about this. Structured cooperation and communication. Timely, structured cooperation and communication. It is the secret sauce that makes the trauma system work. How well people work together and how well organizations work together makes a difference in life and death situations. Think about my own situation that I described. What if whenever you make the call to 911, no one came? Or what if they didn't communicate with each other? Consensus decision making. It's a little, more than a little irony that a trauma surgeon is giving this message, that a group that has historically been so independent and strong-willed, that group of people, along with their nursing colleagues and their paramedic colleagues, realized that you have to make decisions by consensus. In a regional trauma system, you have to make decisions by consensus. I personally think it's a higher level of decision making. I think when it's well done and well practiced in organizations, it does not take a long time. I actually feel like I can do consensus decision making in the middle of a trauma resuscitation if I'm with a team that I know and trust and know what they can do, and I can do that in a matter of seconds. It requires, though, win-win thinking, and we don't all have to agree, but we have to live with it. And in the beginning, it takes time. It does take patience. It takes, like Dr. Hillis said, respect and kindness. How to achieve consensus in a trauma system. The thing that I've found is that we may have strong differences of opinion, you and I. Yet if we're both focused on what's the right thing to do for the patient, we may strongly disagree with each other. We may not even like each other. But if we're focused on what's the right thing to do for the patient, if we're centered on that, you can usually come to a consensus. You have to be careful not to deceive yourself. There's a tendency, I have a tendency, that think that I'm always doing what's in the patient's best interest. So you have to be cautious not to deceive yourself, but it can definitely be done centered on the patient. So what are some behavioral pitfalls of successful people like you, i.e. what not to do? Well, let's talk. I feel more comfortable talking about surgeons because I'm a surgeon, and so I'm going to reference it to me, my tribe. So what are some causes of unprofessional, difficult behaviors in surgeons? Well, to be fair, we, they, you deal with difficult situations, sometimes difficult patients, stressful, difficult situations, and difficult colleagues, and sometimes it's under difficult times. That's just how it is. But there is these tendencies to need to win all the time, to have to win everything, every argument. It makes for some very long meetings. Very long meetings. If I have to win every single argument. And arrogance, the bad big brother of confidence. Arrogance means, to me, confidence is I believe and can see a path for our success. Arrogance means that I think I'm better than you. And I articulate that in multiple different ways. It's very erosive. These are win-lose thinking. I'll talk about it. Tradition. Since I was abused, you're going to be abused. That's a way of thinking about it. Truth-telling. I've talked to some of my closest friends and colleagues, wonderful people. And I said, why did you say that? I said, well, I feel like I need to tell the truth. Well, is it the truth or is it just your closely held belief? Is it really the truth? Or is it just what you believe? Is what you believe strongly always true? The answer is no. A tight-knit family. There's no need to be polite among family. I said, really? How does that work? I'm going to write my wife a memo. Dear Sherry, need ketchup. Loop closed. I wonder if I'm going to get more ketchup. I'm going to get ketchup, but blood is what I'm going to get. Okay, so if what comes across, and honestly, there's a truth to this, that we should be able to be truthful and honest. We should be able to communicate well with each other. But the only way we can do that is if we trust each other. Is if we trust each other, and you trust that I'm being beneficent or beneficial to you. Then you can hear difficult feedback. But if I don't trust you or you don't trust me, there isn't going to be any meaningful feedback given. an excessive need to be me, i.e. colorful, entertaining, controversial. Taken to an extreme, it's selfish. And then pathology, I'm going to briefly talk about it. But to me, the biggest, most important thing is an inability to see the consequences and cost of the bad behavior. It is not benign. It has dollar consequences to organizations, and it has patient consequences. This need to win all the time, to when it matters, when it doesn't, when it's totally beside the point. The related thing is adding too much value. I must give you my 2 cents worth on every point. I must explain to you my point of view. Long meetings. Very long meetings. Painful meetings. Stephen Covey, who I think did tremendous work, I think he has an answer. I've given this talk one-on-one in small groups, and I'm going to tell you what my surgical colleagues say. Is there something wrong with winning? What are you talking about here? I've given people the book, and they've said, I won't use the word they say. But I go, did you have a chance to look at the book? Yeah, I read the first chapter, it's BS. I said, okay, well, we're good. There's really nothing wrong with winning. The problem is, for us as a culture, us as individuals, we're used to thinking of winning as win-lose. I win, you lose. I win the argument, you lose the argument. I win, you lose. That's the way it works in the NFL. That's the way it works in the NBA. Then some of us adopt lose-win. I'm a nice guy. Okay, fine, you win. Well, win-lose people love lose-win people. They're complementary. I win, you lose. Oh, you're happy to lose. Okay, I'm happy to win. Then there's people who honestly just want to win. There's nothing wrong with it. I want to win. I don't care if you lose, but I want to win. Really, win-win. And to paraphrase Stephen Covey, I do think this is very true. Win-win or no deal is the highest level of decision making. And that's the way you have to do it in a regional trauma system. We're going to look for win-win or no deal. Win-win or we're not going to do it. That leads to some really creative problem solving, where you really get to things where you win and I win. And most importantly, the patient wins. Patrick Lencioni talks about healthy teams. I'm not going to go through this. It's a very interesting book. I'll say that Mr. Lencioni kind of poo-poos consensus decision-making, which I'm not wild about, as you might guess. But the bottom line is, I think all these things are true. Trust, healthy conflict, commitment, accountability, and attention to results are all ways to look whether your team is healthy or not. John Wooden says the main ingredient of stardom is the rest of the team. Negativity. I'm going to quickly run through the spectrum. Fatigue. 100% of us have fatigue at times, maybe every day. Virtually 100% of you in the room will have had compassion fatigue at a time. And a very high percent, maybe 100%, will have some post-traumatic stress symptoms. I'm going to talk about these three things. I'm going to, though, highlight PTSD and depression because if you have it, it needs attention. 40% of surgeons report being burned out. 85% of emergency department nurses. 20% of surgeons screen positive for depression. 15% have a criteria for alcohol abuse or dependence. 1 in 16 surgeons have suicidal ideation. 27% of neurosurgeons have criteria for burnout. And what I would think would be a low-risk group, ophthalmology academic chairs. I'm sorry for the ophthalmologists in the room. I really am. I have good friends who are ophthalmologists, but 10% have burnout, and over half are at high risk. PTSD. If you're in EMS, you have a 10% prevalence of a clinical diagnosis of PTSD. If you were a combat medic and you're in EMS, you have a 40% prevalence of PTSD. Trauma nurses, 7 to 10, trauma surgeons, 15%, and those with PTSD have significantly higher rates of depression, anxiety, and suicide. If you have these symptoms, so remember, of the people, the 1,000 people that I'm talking to now, if only 10% have it, that means 100 people. 100 people. If you have intrusive thoughts that lead to decreased attention spans, thoughts of harm to yourself or others, suspiciousness, if you're avoiding triggers and self-medicating with alcohol, if you have behavior changes of appetite, anxiety, fear, irritability, numbness, decrease of hope, purpose, loss of compassion, guilt, if you're hypervigilant, if you have aches and pains, and if you react potentially violently to stressors, these are all symptoms of PTSD. And the good news is, treatment is effective. You're not alone. You're in a room of people who at least 10% in the audience have those symptoms. But if you have those symptoms, treatment is available, and you should seek it out. And if you don't have any outlet, you can call me. And I'm not an expert, but I will find someone. But what about non-PTSD negativity? Starting with no, but, however, you come to me with the problem, and I go, well, let me tell you how that's not going to work. Speaking when angry. Never speak when angry, and never send an email when you're angry. It essentially is a permanent record. Never send an email when you're mad. Call me. If you're really mad, and you just call me and yell at me, I'll say, that's very interesting. Thank you. It's not going to create a problem for you. I tell my people, if you want to yell at somebody, you call me. Yell at me. Because I'm not going to torture you with it. Claiming credit we don't deserve, clinging to the past, telling how it never worked that way and you don't understand, refusing to apologize, not expressing gratitude, not listening, punishing the messenger, an excessive need to be me. I'm going to move along for time. Do we have an inappropriately negative view of our profession? Well, I'm going to walk through as a photographer. You saw me laying on the ground. That's a funny story I'll tell you afterwards about getting EMS and police called for laying on the ground, taking pictures of wildflowers, but another story. It's a true story. Twice. The dead guy on the side of the road. So about perspective. Is our problem, if we have a negative view of the profession, is the problem simply one of our perspective? Or is it actually really substantive? And is there a better perspective? Ambrose Paré, 500 years ago. It's a beautiful passage. I'm going to read it to you. I was but 12 years old when this appetite was awakened within me, seeing and recognizing after a difficult and skillful operation of which I was a witness, how useful and helpful was the science of surgery. He was 12 years old. It appeared to me beautiful and best of all things to work thus for the relief and cure of suffering. From that moment on, I promised myself that this should be the task of my life. The desire and pleasure to be useful was my principal aim, and since then I have always moved towards that end. He first changed himself, he then changed surgery, and he changed the world. This is a bluebonnet. It's a beautiful, delicate little flower. It's enduring. It's very tough. It's a weed, though, of the pea family, and it's endemic to South Texas and Central Texas and Oklahoma. That's Lady Bird Johnson down there who propagated these flowers by her highway beautification projects. Well, this is a typical field of bluebonnets. It is. It's in a vacant lot in San Antonio. You can see them in the bottom left corner. You may not notice them. The little bluebonnet's going to be my metaphor for the profession. Actually, now we can see the bluebonnet. We're at its same level. We're looking at it. We're up close. We're paying attention to it. It's a pretty flower. But we weren't really looking at it in the appropriate light. Now, with the soft, gentle light shown on the flower is beautiful. Then, if we're paying attention to it and sunset happens, this flower can be seen in all of its glory, its true beauty. It's not a weed. It's a beautiful little flower. So we can reframe our profession from a different perspective, shine a soft, gentle light on it, and view the context of the profession of medicine and nursing and paramedicine from a different point of view. How? How to do that? How to do it in a way that leads to improved patient care, better physicians, and a better society. Sherman Goodwin, 1814 to 1884. I didn't know who Harry Ransom was. The Harry Ransom Center exists at UT Austin, where there's a Gutenberg Bible, and the first photograph ever taken is in that Harry Ransom Center. Harry Ransom must know something. Well, he wrote about Sherman Goodwin, who was a New Englander who moved to Texas in 1849 to a primitive outpost in Texas, and he was quoted in a Texas surgical address, so I knew him. Victoria at the time was a primitive outpost. And I asked myself, is our world compared to Dr. Goodwin's world, is it less convenient, less comfortable? Do we have less support? Do we have less knowledge? Do we have fewer resources? Do we have lower pay? The answer is no, 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 no. It's all better. He's writing to himself in a journal that he never thought anyone else would read. He's writing to himself, and my favorite part of the whole paper is where he gives 7 reasons why he practiced medicine. I'm going to give you the 2. How many times is the doctor asked, why science, why medicine? The doctor's words are subtle and unsure. He says, first, the sense of life going on, of questions outcropping, of natural, expected answers, and of unexpected answers, of wonder, the wonder of medicine. Second, he says, there's the working of a cure. Think about 1849. There were not many cures in 1849. But we have cures today that deserve a celebration, that deserve high fives. If you take the appendix out of someone who had acute appendicitis, that is a life-saving procedure. Hernia, burn, long bone fractures, hemorrhagic shock, pneumothorax, all life-saving, yet we don't really consider them reasons for high fives. And he says, sixth, in time, the physician must rise up to the enlistment against the powers of evil, and it is something to have labored for the betterment of life. You hear the echoes of Ambrose Paré in his words. One life. So a young boy had traumatic arrest at the age of 3 from a dog mauling. He's now a sophomore in high school, straight A student, doing great. What is the value of one life? 1950, July 24th, 1950, my mom was in this car crash. If my mom wouldn't have survived, I never would have been born. I've already told you my story. So we can reframe the profession from a different point of view. In my mind, a more correct point of view, and shine a soft, gentle light on it, and look a point of view that shows the beauty, the true beauty of the profession. It is really our responsibility to do so, mine and yours. 7 P's to be: participatory, professional, problem solver, process improvement, passionate, perseverant, and patient. Thank you.
Hey, where are you going? Wait a second. So, on behalf of the Arizona Trauma Association, I present you with this award for the 7th annual Thomas WACHTEL keynote lecture. I really appreciate it. That was
Thank you very much.
amazing talk. Thank you. Great, thank you.